Açtın mı Recai?
Tamam.
Okay. So, Pankaj, I will spend some words in Turkish and pass the stage to those guys. Is it okay for you?
Yes, that's perfect.
Herkese teşekkür ederim. Ben esasında Mustafa ile Gören'e sadece yardım ediyorum. Bütün sunumu onlar yapacak arkadaşlar. Sorularınızı bu Zoom'dan ya da YouTube'dan yazılı olarak iletirseniz Pankaj'a yönlendireceğiz. Birkaç tane hani girişte Pankaj Guys Hospital'da sorumlu öğretim üyesi olarak çalışan öğretim üyelerinden biri. Geçen yıl yaptığımız abdominal organ çıkarım kursunda da bizle beraberdi. Onun dışında ilginç olan şey Pankaj için, Pankaj sadece yaptığı çalışmalarla tıp dünyasının ünlü değil, aynı zamanda esasında bir film sektöründe de ünlü. Belki Netflix dizisi olan Crown'u seyretmişseniz Pankaj'ı hatırlarsınız. Biliyorsunuz orada iki tane sahne var. İki cerrahi sahnesi. Biri King George'un ameliyat sahnesi. Sonra daha sonraki 3. sezonda da bir ameliyat sahnesi var. Orada Pankaj esasında ameliyatta rol alan cerrahlardan biri, gerçek sahneyi gerçekleştiren ve bu sahneleri de gerçekleştirirken 3 boyutlu yazıcı teknolojisi kullanarak oluşturmuşlar. Bunlardan hepsinden bahsedecek. So Pankaj, I just give a hint how big celebrity you are. So Gönen and Mustafa, you can just start.
Hepiniz hoş geldiniz arkadaşlar. Ben Gören Arık. İki dilde de yapacağım bu konuşmayı. Çünkü yabancı katılımcılarımız da olabilir. Üç boyutlu yazıcı ve transplantasyon cerrahisi etkinliğimize hepiniz hoş geldiniz. Bunu Mustafa Kağan'la, yani Hacettepe Tıp Öğrencileri Birliği ve ben Ankara Tıp Öğrencileri Birliği, aynı zamanda Türk Hepatopankreatobiliyer Cerrahi Derneği ile birlikte yapıyoruz. Hepinizi burada görmek çok güzel. Öncelikle aynı zamanda Acar hocamıza çok teşekkür etmek istiyorum. Bize böyle bir fırsat tanıdığı için. Aynı zamanda Pankaj hocaya çok teşekkür etmek istiyorum bize katıldığı için. Bu çevirdikten sonra Mustafa'ya sözü bırakacağım. Hello, welcome everyone. My name is Gören Arık. I'm Ankara University Faculty of Medicine second year student. I work as a local officer on research exchange in my faculty. After that, I want to thank Acar, Mr. Acar, because he set this up for us. And I want to thank Mr. Pankaj for joining us. It's on you, Mustafa.
Teşekkür ederim. Evet arkadaşlar, hepiniz hoş geldiniz etkinliğimize. Ben Mustafa Kaan Köksal, Hacettepe Üniversitesi 2. sınıf öğrencisiyim. Ben de Hacettepe Tıp Öğrencileri Birliği'nde dönem 2 araştırma değişimi sorumlusu olarak yer alıyorum. Acar hocamıza ve Pankaj hocamıza çok teşekkür ederiz bizleri kırmadıkları için. Hello everyone, welcome to our event. Thank you for all us to coming. I'm Mustafa Kaan Köksal from Hacettepe University, Phase 2 student. On Hacettepe University Medical Association, I'm work as local officer on research exchange. I want to thank Mr. Tüzüner for supporting and helping us to organize this webinar, and thank you to Mr. Çendak for being with us. And now I'm yielding the floor to Mr. Çendak.
Mr. Çendak, before that, can I add something, please? Okay, dear... arkadaşlar, öncelikle Türkçe söyleyeyim. Sorularınızı YouTube chat'ten veya Zoom question answer kısmı var. Buradan direkt sorabilirsiniz bu webinar olduğu için. Biz buradan okuyacağız direktlikte sunumdan daha sonra. Dear friends, you can ask from question and answer part of the Zoom or YouTube chat parts. You can ask questions. We will ask these to Pankaj, Mr. Pankaj, Mr. Çendak. Thank you.
Great. Well, thank you very much for the warm welcome and the invitation again. And thank you all for coming. I know it must be late there, so I promise I won't keep you too long. So I'll just try and share my screen. Can you see this?
Yes.
Yes.
We can see.
Excellent. Perfect. Okay. So, lovely. So basically, my name is Pankaj. I'm a transplant a surgical registrar and also a research fellow at King's College London. I've been asked to talk today about the use of 3D printing in complex transplantation, which formed some of my PhD research over at King's, and in particular how we use this technology now in some of our most difficult transplants. So let me just go through. So just before we begin, the idea of human organ transplantation has been around for quite a while now. As you can see from this slide here, from this painting, it's been around since the 1400s. And essentially, what this means is that you've got two saints here that are painted, Saint Cosmos and Saint Damien, and you can see them replacing the leg of this man with the leg of another man. So the idea of replacing a diseased human body part has been around since the 1400s. And now I'm sure they knew nothing about immunology or nothing about basic science, but I think the pure concept I found was really fascinating, that this is going back almost, a few centuries. And then if we skip forward to this gentleman here, some of you may know him or heard of him. His name is John Hunter, who a lot of people believe is the father of modern day surgery. And about 300 years later, after this painting was created, he did a lot of experiments. For example, he put a human tooth into the head of this hen, of this bird, and then he dissected it. And he found out that the human tooth itself was embedded inside this head of the hen. And it's quite remarkable. This is the first example of what we call xenotransplantation across different species. Of course, he knew, again, nothing about the immunology of these things, but what he then went on to do was lots of tooth-to-tooth transplants between humans, and gave a lot of people syphilis, actually, that way. A lot of people ended up dying, sadly, but still, that was the first example, if you like, of xenotransplantation. And then if we move on to modern times, we can almost transplant any organ now. I had the great pleasure of being on the BBC World Service Radio in 2017 with a panel who were celebrating the first human heart transplant performed by Christian Barnard in South Africa. And on the panel was Professor David Cooper, who's a professor of cardiothoracic surgery, cardiothoracic transplantation in America, who knew Barnard quite well. And he was telling me how actually, Barnard was extremely scared, really, for the first time in human history, when you have a patient lying there who's ventilated, who's under anesthesia, and for the first time in human history, the chest is empty because he's now going to put the new heart in. And the whole world is watching him. And it's quite amazing that it's taken so long for us to actually come down to cardiac transplantation. The heart's only 10 centimeters away from the sternum, but it's taken us almost 2,000 years to get there. So that was a real landmark. And of course, we can do kidney transplants, uterus transplants, any solid organ transplantation, really. But there are still challenges that we're facing in the transplant community, such as lack of organs, lack of good quality organs, and indeed how we can transplant very high-risk recipients surgically. And indeed, one of the most difficult transplants that we do in our hospital, in our unit, is in children, pediatric transplantation. And this really stemmed the main inspiration for my PhD research on 3D printing, because how can we make surgery safer for complex transplants in children? So here's an example. Here's we'll be coming back to this case later on, but this is Lucy. She was 10 kilograms at the time of her transplant, and she was getting a living donor kidney from her father, Chris, who was a 35-year-old male. And that was quite a complex transplant because she was quite small. She had lots of previous surgery. The abdomen was quite scarred. And I'll come on to how we use 3D printing for that. But just to go back a little bit, we know that you know, transplantation is obviously the standard treatment of choice for end organ failure, offering better survival benefit and better quality of life. This graph, just from North American data, shows that essentially you have to transplant children quickly, the younger they are, because smaller children have poor outcomes on dialysis with longer duration. And hence, it's important to get these very small children a transplant as quickly as possible. And ideally, a living donor transplant, because they offer better survival, better growth, better cognitive development, better psychology, and better quality of life. These are all fairly obvious things, but it's actually vitally important to try and transplant children as quickly and timely as possible, because these organs may last up to 20, 30 years, possibly if everything goes well. And then, of course, they may need another transplant after that. And of course, you want to get them off dialysis as quick as possible. But there are challenges in pediatric transplantation. So what are those challenges? Well, the first is we're trying to fit an adult-sized organ into a small baby. So this could be an organ from mum or from dad, or indeed it could be from a deceased donor. And you may be wondering why we don't use pediatric small kidneys for children. Well, the reason is essentially that these small kidneys from children, they have a high rate of thrombosis and also more subject to hyperfiltration injuries. So we tend to go for adult organs for children for longevity and less risk of thrombosis. But of course, there are technical challenges with that. How can you fit some of these large organs into very small children? Can we close the abdomen? And even if we close the abdomen, how is that going to affect the intra-abdominal pressure? How is that going to affect the perfusion of the organ once it's inside the abdomen? Will that be compromised because of the high pressure inside? And of course, how will it affect breathing? Because a lot of these children are obviously ventilated and intubated. And of course, it may be difficult for the anaesthetist to manage their respiratory support if you have a very large intra-abdominal pressure compressing your chest, for example. So these are all the issues that we need to think about. So, you know, size mismatch ratio, essentially, which is more prevalent, well, sometimes more important in pediatric liver transplantation. But there are also further challenges. So it's not just size, but it's actually the blood vessels of the child. So if a child is less than 20 kilograms, we would consider that a small child. We can go smaller, obviously, less than 15 kilograms. And normally we put the kidney onto the aorta and vena cava of the child, and this is done through a midline laparotomy incision. And you can see here the IVC and the aorta, and we implant the kidney onto this. And this is a technically challenging operation, and this is ideal anatomy. But what happens if you're presented with a child that has very complex anatomy? So here's a child, it's a 3D reconstruction of a child who's 6 years old who had aneurysms of the aorta, and at the age of 3 underwent a supraceliac to aortic bifurcation PTFE graft. So this is an operation that you would normally do for adults, right? When you have an aneurysm. But this is an aneurysmal repair from a child. And this was an extra anatomical bypass graft, and they reimplanted the visceral vessels, for example, the IMA and the SMA, into the plastic graft itself for aneurysmal disease. And so you can see now we have a situation where you have a plastic graft here, you've got a reimplantation of the vessels, and you can see it's a complex meshwork here. So this child presented to us for transplant, and we had to find a landing zone for the kidney. So where could that be? Well, it's very difficult up here. This is quite surgically challenging to put the kidney onto here. You could implant it onto the graft, although that's also got its problems, but there might be a small space here just beneath the graft, but that was quite hard to appreciate in terms of orientation on these 3D images, which are essentially on a 2D computer screen. And it requires a radiologist to interpret this sometimes and convey that information to the multidisciplinary team. And so you can risk stratify some of these abnormalities. So here's a paper we published in 2017. And what we did was we classified some of these abnormalities based on aorta and vena cava patency. So if the entire aorta and the vena cava were patent, they would be classified as A1, V1, which would essentially be normal anatomy. But if they were completely absent, they would be A4 and V4. So for example, this child's aorta, abdominal aorta was essentially absent. So this would be classified as an A4 case. And in fact, this child also had no IVC, completely occluded. And you can see dense collaterals here. These are gonadal collaterals, dense pelvic collaterals. So this child had no IVC as well. So this would be A4, V4. So essentially everything is missing. So this could be a classification that we could use to help stratify risk management towards these complex children. And so what happens is that these are the complexities involved in interpretation of 3D structures on 2D screens. So as I said, you cannot interact with these images. It's difficult to simulate any operative procedure. And what we do in this situation, when we have a child with complex anatomy, we're not quite sure about the feasibility of the procedure, we have direct surgical exploration on table. So we put the child to sleep, we open up the child, we determine anatomical feasibility of transplantation, and only once we've confirmed that do we then give the donor surgeon the go-ahead to take the kidney out from mom or dad. So the donor is not yet asleep, they're in the operating theatre, usually at a different hospital, which is Guy's Hospital, and the child could have the abdomen open while we determine feasibility at Great Ormond Street or Evelina Children's Hospital. So now the donor surgeon is under a bit of time pressure now to take the kidney out safely. We put it into ice, transport it across London into the Children's Hospital, and obviously you can imagine that adds some complexity to the overall transplant experience and can be a very demanding and stressful time for both teams as well as for the families. So essentially, how can we try and make this process slightly less risky and try and determine feasibility before surgery? So that was the question that we had to ask. Can we predict feasibility in the presence of complexity using 3D printing? So I'm sure some of you may know a lot about 3D printing. I didn't really have much of an idea about it until I got involved with this work. In fact, I was just going to a very random lecture in the hospital on 3D printing in cardiac surgery. And one of my bosses told me to go to the lecture and see if we can, see it out of interest, really. And then once I went to the lecture, I learned a little about 3D printing, and I thought perhaps this could be used for some of the work that we do. So this chap here, Charles Hull, he is the father of 3D printing, we say. He's he lives in America, and essentially he discovered this process of 3D printing when he was trying to use UV light to harden tablecloth, actually. And 3D printing really is an additive manufacturing type technology where you build an object from the bottom up, usually UV light, which sort of molds liquid plastic resin based on extracted imaging data to create a model. And it's been used in industry for quite a while. For example, cars. I mean, this is a car that I would love to have. This is a 3D printed car. I'm not sure really how effective it is, but it looks very good. You can have 3D printed exo-type skeletons for people who have fractures, for example. And it's become a great fashion item now, I suppose. And also orthopedic surgery and maxillofacial surgery have been using 3D printing for implants. And of course, you can now have 3D printed pills. But it's just emerging in the field of transplantation. So here's an example of a paper. This was the Japanese group that developed 3D models for transplantation in adult surgeries. This is not for pediatrics. And this was really a proof of concept. There was no real complexities with the cases that they presented, but it was just a proof of concept to show that you could 3D print and use it as a simulator for training. Likewise, we've used 3D printing for complex pre-planning for living donor liver transplantation. You can see here the complexities of the anatomy here and also here, and it correlated well with the dissected specimens here. And this is an interesting paper using 3D printing for pediatric liver transplant. And what they've done here is they had 10 patients in the 3D printed group versus 20 control patients. And what they said was it facilitated surgical planning and procedures in the management of hepatic veins and large Versailles syndromes. But interestingly, the donor time, operative donor times in the 3D group was significantly shorter compared to the controls. So that was a nice piece of work looking at pediatric liver transplant. But it's never really been looked at for pediatric renal transplants. So what was our approach? Well, the first thing we had to do was a proof of concept using Mimic software to actually see if we can 3D print an adult kidney in a child's abdomen as a proof of concept and to see if the geometries all correlated. And then the next step is then to translate this into clinical practice to see if we can use it, see if it's useful, and then we can assess it, especially in those cases where feasibility is uncertain. So just to take you through what's actually involved here. So this workflow diagram shows the process of how we make these models. So essentially 3D printing relies on the extraction of anatomical data from MR scans or CT scans. So they've got to be high quality MR or CT scans. And we have image acquisition and then image segmentation, where you essentially draw around the actual anatomical data that you're interested in. And this is done usually with the medical physicists, in-house with us, and also the in-house interventional radiologists. And then we subject the computer-aided designs here through various software such as Mimics via our 3D printer here to produce a three-dimensional patient-specific model. Now, this is a state-of-the-art 3D printer, which is in our medical physics unit at St. Thomas's Hospital. It's about £250,000, and it's used by different specialities. And it can actually process the computer-aided designs and make shapes and models in different properties, if you like, of the materials. You can have soft, you can have hard, and I'll come on to that a bit later. So here's an example of a heart that we're creating here. So this is my colleague Nick Byrne, who works with me on this project. So we can see we're drawing around the various aspects of structures in the chest, and then you'll see a computer-aided design of a pediatric heart forming here. Now this process is actually quite time-consuming, although we've sped it up here for the slide. But essentially, this process can take up to 30 hours or so. The fine refinements to produce this image, and there's some interesting work using artificial intelligence to try and make this process more streamlined. And here you can see the printer head, which essentially cures liquid plastic resin and the UV light to form a morphological shape. And you can see the shapes here are in different colors and different sizes. So the printer is using its intelligence essentially from our programming to create a patient-specific model. And this process can take up to about 12 hours. So by the time we get a referral for a case, it could take about 4 weeks for us to get a model. Obviously, we can do it faster, but we only have a limited amount of staff working in the medical physics unit. And as I said, this process here takes quite a long time. So here's our proof of concept. Now, if you remember, I showed you the case before of the 6-year-old child who had the aneurysm. So we actually transplanted her without 3D printing. So what I thought we would do is go back to this case and then retrospectively print the models and see if they would have been useful for the surgeons at the time, because this is a child, as I said, had to be explored on table first, which took about 3 hours or so, to find a space of aorta just beneath the graft in which to place our kidney. So what we did was we went back to the images, we created a computer-aided design, and then we created a 3-dimensional model, and it showed geometrical correlations between the CT scans and these computer-aided designs, and also the segmented final product. We showed it to 5 independent surgeons who confirmed actually this model would be very useful at the time of transplantation to work out exactly where the graft comes onto the native aorta, to work out how much space there is actually to plan your arterial anastomosis onto the aorta there, which was actually encased in a lot of fibrous tissue. And you can see as they're surgically manipulating this as a simulation. So there's the donor kidney, and there's the artery, and you can see there's the graft just there, and there's the anastomosis, planned anastomosis for this case. And so what we then want to do is work out some validation. So is the printer actually producing what you're putting into the printer? So this was some nice work done by Nick Byrne, my colleague. What he did was he had the computer-aided design that we put into the printer. And then what we did was we CT scanned the models, then produced, well, this model here, and then we produced the computer-aided design of the actual CT scan of the printed model. And then what he did was he drew a center line down the vascular tree and worked out the diameter at different points along this vascular tree for both images and compared them. And what he found was that the diameter of the printed model is smaller than the original input file by 0.1 millimeters, comparing favorably within the limits of surgical precision. In other words, the diameter captured in the input files is well reproduced by the 3D printer. So that was some quite complex mathematics, but essentially what we're putting into the printer is what we're getting out. And so I spoke earlier about how we did a proof of concept, and then the next step is to translate it into clinical practice. So, okay, so what sort of clinical scenarios can we now use this technology for in the context of pediatric kidney transplantation? So this is some work that we published last year. So this was the small pediatric recipient. This is the 2-stage procedure. And then this is the small pediatric recipient who also has complexities of the blood vessels. Okay, so we'll go through each of these very quickly. So let's think about the small pediatric recipient. Okay, so this is coming back to Lucy. Remember Lucy at the very beginning? And this is her father, Chris. So we produced an entire CAD design of Lucy's entire abdomen. And we then produced a 3-dimensional model of Chris's kidney here. Okay, so as I said, she's 2 years old at the time. She has 10 kilograms. She had lots of previous abdominal surgery for bowel ischemia before she came to us for transplantation. So we were worried about scarring and distortion of anatomy. And you can see here the size discrepancy. So this is a case of the small recipient. So we have to get that essentially into this space here. And these are the native kidneys here. You can see the liver. You can see the pelvis, and the printer has the amazing ability, as I was saying, to print in different properties. So the liver and the lateral abdominal walls are printed in a softer material, as are the vessels, whereas the pelvis is printed in a very hard material, just trying to reproduce, if you like, what it's like in the human body. It's not exactly the same for the soft tissues, but it's something that we're working on. But this is very much like bone. So that gives us an idea, if you like, of depth perception and of the boundaries of the box, if you like, of the abdomen that we have to put the kidney into. So this is just a slide, a video, I hope it works, of my professor showing you how he used the models before the transplant. So this is a few days before the transplant. So here he is, he's now working out the best possible approach of the donor blood vessels to the aorta and vena cava of the child. Okay, working out the best lie of the kidney within the abdomen. And critically, the model gave us depth perception. So it told us whether we had to mobilize the liver, whether we had to take out Lucy's right native kidney, which you can see here is the size of a little walnut, little nut. And the model told us perhaps we didn't need to do that. But of course, that's a decision you take at the time of surgery. But you can see how it helps us to gain an idea of the best possible approach to the vessels and the kind of manipulations we may need to do and the line of incision. And of course, we can take it to the family and it can be used for consenting. And you can see here the kidney, as it was planned on the model, lying beautifully within the abdomen, and the dimensions of the blood vessels also correlated quite nicely. So that's a case of the small recipient. Now here's another case of a 12-kilogram child who presented for transplantation, who had bilateral renal artery aneurysms, but also an aneurysm of the inferior mesenteric artery. Okay, so it's quite a complex arrangement now of anatomical abnormalities. So here is the actual 3D printed model. So you can see very dysplastic looking kidneys. You've got aneurysms at the renal hilum here, and you've also got an aneurysm coming off the IMA. All right. So this child underwent, if you like, a staged procedure. So the first part was to actually undergo bilateral nephrectomy using the help of 3D printing to help plan that approach. So this was done at Great Ormond Street by one of our professors of pediatric neurology. He did a posterior retroperitoneal approach to both kidneys and to the vessels. And of course, he planned this on the model and he transected them accordingly to the model, which we found very helpful prior to the operation. So this child then, we have those kidneys removed. The child had a period of dialysis before transplantation. So the reason we wanted to correct all this was the risk of these rupturing during or after the perioperative period after the transplant. So it's important to get these kidneys out first. And here you can see the living donor kidney, and you can see how we planned the anastomosis just beneath the IMA. But then we had the difficult task of working out what to do with this aneurysm here from the IMA. And the model, you can see, gave us an indication that perhaps we could transect it here and remove the aneurysm successfully and then oversew it and repair it. And that's exactly what we did. So you can see here again, planning of the kidney. There's the renal vein, there's the renal artery, and you can see the space here that we used for the anastomosis of the renal artery and the space that we used for the renal vein. And you can see the aneurysm just here that we plan to resect using this model. So this is an example of use of 3D printing in a staged procedure for a child who needs two separate major operations at different time points. Again, a rare case, but it's something that was a novel indication at the time. And then the third case is essentially, as I said, a child who's not only small, but has complex vascular abnormalities. Now, these, as I mentioned, they could be blocked, they could be missing, they could be narrowed, such as mid-aortic syndrome, or they could be twisted. So these vessels can have any one or all of those things, essentially. So here's a child, again, a young child who presented to us for transplant, and you can see the IVC looks fairly normal, but you can see the aorta is bifurcating very high up. So it's a very high bifurcation, and it's got a complete twisting of the branches of the aorta, like a trouser leg, essentially, configuration. In fact, it's called a trouser leg configuration by the radiologist. So when we presented this child to the MDM, our multidisciplinary team, for consideration of transplant, the surgical team were divided in their opinions. Some said yes, some said actually it's not feasible. So we 3D printed it. We took it back to the multidisciplinary team. And in fact, all the surgeons then said, actually, this is feasible. So here's the 3D model. There's the IVC, and here's the aorta. Unfortunately, it's still in the same color as blue as the IVC, but you can see here the aorta dividing fairly high up and complete trouser twisting motion there. Yeah. And that's the planned anastomosis using the living donor kidney there. And we took the model to theatre, and we planned to anastomose the artery of the kidney onto here, and the venous anastomosis here, and that correlated exactly to what we found in the operating theatre. And indeed, we had the model with us, and that's exactly where we planned to put the kidney onto, and this child had a successful transplant. Here's another child, 15-year-old male. Again, IVC completely blocked, so lots of dense collaterals, okay? You can see that here. We 3D printed this as well for planning purposes. Again, there was some divide in the multidisciplinary team about feasibility, but once we printed the model, we determined actually that this that the venous drainage of the kidney could be placed on one of these large collaterals here on the left. So that was another example of 3D printing used when you have complex venous anatomy. Here are some of our cases so far. I've talked about some of these. Essentially, we've done about maybe almost 20, 25 cases now with good results using 3D printing. But you can see essentially these are small children, except for this one here, quite young. And we scored these, surgeon score 5 means excellent, patient score 5 means excellent. So, you know, these models we used for consenting and for explaining the procedure to the families, which they found extremely useful as well. So coming on to the future, where will we be in a few years? So this was 3D printing for planning, but also there's an exciting area of 3D bioprinting. And this is where, and decellularization, recellularization, and stem cell organ regeneration. So imagine you have a human liver here, for example, and you completely decellularize it. So you remove all the cells from the liver. Essentially you're left with the exoskeleton, and then you can use stem cells essentially to then repopulate that scaffold and direct these stem cells to perform physiological function. Now, the kidney, you can see an example of a kidney here being decellularized, is an extremely complex organ. It's more complex than the liver. So, you know, the kidney has more than 30 different types of cells within it, working synergistically, physiologically, and homeostatically to maintain acid base, for example, your electrolytes and your fluid balance. So that's taken many, many years of evolution to get to. But what we're trying to do here is reproduce that in a few years by using growth factors and differentiation factors to direct stem cells towards mature cells that we can then populate into the kidney. The main problem with the kidney also is, and with all organs actually, for using this type of approach, is how we're going to vascularize the organ. So you can imagine we've got very delicate blood vessels, and if we try and create blood vessels using this technique, some of them may just fracture with variations in blood pressure, because obviously your blood vessels have had many years of evolution to adapt to the differences in blood pressure. But if you're creating new blood vessels, sometimes they may not withstand very high blood pressure, they may fragment. So that's one of the Achilles heel, if you like, of trying to recreate organs in that respect. But the idea would be that you can get a scaffold and then repopulate it with the patient's own cells, stem cells. So in other words, to the patient's own genetics, so that the patient may not have any immunosuppression. So there's some exciting work going on around the world looking at organ regeneration, which I think is the next big step in transplantation. How else have we used 3D printing in our unit? So this is Professor Nizam Mahmood, and this is Nikos Kasaris, and this is Professor Pranjal Modi. So in our unit we did, in 2016, I think it was, the UK's first robotic kidney transplant. And this was helped by Professor Modi, who came from India, who's done over 500 of these, probably the largest experience, well, it is the largest experience in the world of robotic kidney transplants. And the idea here is that you have a minimally invasive technique of kidney implantation, which means that patients can have faster recovery with less pain compared to the conventional open approach. And we use a Da Vinci system here. And there's Professor Mahmood unscrubbed at the Da Vinci system with the console. And you have a team of surgeons scrubbed. Here's a Da Vinci robot. And then we make a small cut to place the kidney inside the abdomen, and then we robotically suture the blood vessels onto the iliacs, and the ureter onto the bladder. And the first 2 cases that we did, the patients went home in 4 days with very minimum pain relief. In fact, Professor Modi has also done pediatric robotic kidney transplantation in about 40 children now, I think, and he's had very good results with that. In fact, he also uses natural orifice surgery. So in women, he will place the kidney through the uterus, make a hole, place the kidney into the abdomen, and perform almost scarless surgery on that. So it's absolutely amazing. He did about 300 laparoscopic kidney implantations prior to robotic transplantation. So that was his learning curve, if you like. So the idea is that you've got minimally invasive surgery here for kidney implantation. Now, obviously, that requires a high level of skill. Some people say it's almost like flying a plane, a fighter plane, in a blizzard, while trying to flip a pancake at the same time. That's the kind of level of skills that you need to do some of this robotic kidney transplantation. So the idea is, how can we train junior surgeons in this technique? Because it's something that we think is going to be here for the future. So what we did was create a hybrid model for training of junior surgeons using 3D printing. So this was developed by my colleague Yanis Lukopoulos, who's one of the consultants at GEIST. What we did was we 3D printed a real human, well, we 3D printed a human pelvis from a real patient, and then we had the kidney there, the living donor kidney. And then what we did was we actually created deliberate gaps, if you like, in the 3D model where the blood vessels are, and in between those gaps we actually put real blood vessels from deceased donors, from a bank of tissue that we've got. And then you can see how we place the whole thing under the robotic arms, and then we practice the stitching of this under robotic conditions, which we've got to try and do in about 40 minutes. So let me show you a video of that, of how we use that. So that's why it's called a hybrid model, because it's combining 3D printing with real human tissue. So here's a life-size kidney. You can see that there. Here's the 3D printed pelvis. You can see the gaps we've deliberately kept. Okay, here. And here's the 3D printed kidney that we're going to use. And these gaps have got serrated edges. And what we do is that we then take real blood vessels that we've got from a deceased donor, and we essentially place that in the gap here, okay? And we secure those in place by stitching, by suturing, and then we place the whole thing under the robotic arms. So now you can practice your stitching technique with this. And again, we attach blood vessels to the vessels of the kidney as well. So you can see, this is the actual practice that we're doing now. This is Professor Modi now practicing with this. So there's the donor vessel. This is the recipient vessel. And this is actually what you do in real life, except there's no blood here, but this is the real life situation. This is the robotic Da Vinci working away, stitching, you can see. This is the donor vessel. This is the recipient external iliac artery. So you can see that there. Okay, there's the kidney. And same thing here. So you can see that's how it's a very useful model for training and for understanding the way in which you can do a robotic anastomosis. So that was really nice, and that's been validated now in a larger study. We also use 3D printing for prostate cancer. It's not directly related to transplantation, but this is Professor Prokar Dasgupta, who's Professor of Robotic Surgery, who works with us, and he's been using 3D printing now for prostate cancer. So here's a 3D printed prostate. There's the cancer that's been outlined, exactly how it was when he resected it. And we've published that paper in 2018 in BJU International. Over the COVID pandemic, this is just a sideline really. We used 3D printing and our expertise to develop PPE actually for the COVID pandemic. There was a shortage of PPE in London, so they set up various 3D printing farms around London in association with our university. So lots of students came in their spare time, I came in my spare time, and we helped create lots of these visors using 3D printing, which was a very an amazing team spirit to try and help the cause for COVID. So just coming to the end now, really. I mean, so what have we learned from 3D printing so far? So I think, you know, as I said, it's a technology that's been around for almost 40 years. And it's been used in industry for quite a long time. It's only emerging in certain areas of medicine. And I think what this told me was that innovation and creativity in medicine can really happen, if you like, at the interface between the physical and biological sciences and clinical medicine. So I think we can learn a lot from the physics guys or the biologists or the chemists or the engineers, and likewise they can help us address our clinical problems. And I think that's where the real heart of innovation and research lies, is that interface between the two, because they want to obviously use the technology to help us, and we want to use their expertise to help our patients. So from this experience so far in 3D printing, we've learned that, you know, we can understand the anatomy, we can translate it clinically, we can allow surgery to be simulated, we can allow consenting for the families, which is very important, especially when procedures are not performed so regularly and you can't quantify a risk of a particular operation, but you can explain it on a model which is patient-specific for them. And you can develop a collection of these models for training of future surgeons because they capture the anatomical complexities, which sometimes you may only see first time as a consultant surgeon operating with another colleague. So I think that's quite important, that you can use these models for a variety of different advantages that perhaps wasn't there before. Here's just some pictures, actually. Here's Lucy at the time of her transplant. This is mum and dad. You can see Lucy here now. She's almost five or six, handing her models over to the Science Museum, where they are displayed in London. And she's absolutely amazing. She's become an ambassador, really, for UK transplantation. So her story's been read quite a few times. In fact, when she was transferred over from Ireland to London, when she first became quite sick, she was actually transferred over by Prince William, by the helicopter service, which was quite nice. So we call her the Royal Princess. So that's quite nice. And just to end on a couple of quotes, really. This is one of my heroes, Joseph Lister. I'm sure you're all familiar with him. He's a professor, well, he was a professor of surgery at King's, at my own institute, and also in Edinburgh and Glasgow. He pioneered antiseptic surgery. And what he said is that there is only one rule: you must put yourself in the patient's place, which I think is a very powerful saying for any healthcare professional, medical student, doctor, whatever you go into. I think it's really important to remember that. Only put yourself in the patient's place. So here's Professor Modi again. You can see from India. He works in a very, very basic, very sort of under-resourced government hospital. And this picture is quite amazing. He drove almost 200 kilometers or so to harvest some organs from a child that had died. He brought back the liver and both kidneys, and he transplanted all three of these children in 24 hours. So this child, I think, got the liver transplant, and these two children, one got the kidney, the other one got the other kidney, all in 24 hours, which I think is quite amazing. And you can see them sitting up, looking very happy there. So again, I think that exemplifies this quote: put yourself in the patient's place. Here are all some of the children that we've transplanted at Evelina Children's Hospital in our unit. This is a choir that we set up called Harmonies of Hope with the BBC, Children in Need. We appeared on the BBC News, I think it was a couple of years ago now. And all these children have a remarkable story. Each one really is very palpable in terms of their journey. And of course, these are other examples of children that we've transplanted successfully. And there's Professor Mahmoud there as well. And just the last quote really from a scientist, one of my heroes, again, not a surgeon, but a scientist. And he said, we must keep trying because who knows what is possible. And I think that's a really important saying, because unless we really go beyond our comfort zone and go up to the horizon, we don't quite know what's possible. When we think something might be impossible, we're not quite sure. You have to keep trying because really we don't know what is possible and what isn't. So with that, I'd like to finish really, and thank you for your time. And I hope I haven't gone on for too long. I just want to say thanks to all my collaborators and also my supervisors. And I'd like to thank you all for giving me a chance to share some of our work and some of our journey. And I hand it back to you. Thank you.
We are thanking you so much, Mr. Chandak, for your wonderful presentation. Before to get into Q&A session, I have an announcement for the participants. We are sending a roll call form now. You can fill it from here and YouTube.
Thank you very much for your... Okay.
Arkadaşlar, yoklama formumuzu YouTube ve üzerinden paylaşıyorum. Devam edersek doldurursanız çok mutlu oluruz.
Thank you very much for your valuable presentation, Mr. Chandak. We will continue with the Q&A session now. We got some...
Çocuklar, arkadaşlar, önce birkaç kelime söyleyebilir miyim ben?
Of course. Tabii hocam.
Dr. Chandak, thank you for this excellent presentation. I was so lucky. I think this is the second time I had this very amazing lecture. So this group is mostly from medical students. So most of the audience is medical students. So apart from transplantation or the amazing work you have done, I think the most amazing thing is taking a small idea and growing it with the scientific process, scientific thinking, and making a clinical reality and a solution for the patients. I think this is the amazing work apart for anything. So all of the students here, they should make an example of you, how science and scientific thinking process can make things happen. You need to think, freely, not afraid of anything. Failure, particularly fail, try again, and the success will follow. So thank you. I think all should take you as a good example.
Okay. Thank you very much. I'm going to read the first question. It's from Ilgas. In organ transplants, does the donor organ connect to the patient's nervous system, for example, the vagus nerve?
Yes, good question. No, we don't generally connect it to the nervous system. We make sure that the kidney itself has a vascular supply. That's the key thing. But there is some evidence to suggest that the kidney develops its own auto-regulation once you connect it up. So it's got its internal system of how it monitors, the sort of nervous responses. So it can auto-regulate the blood flow. And in fact, going back to another thing that we've seen sometimes, speaking to Professor earlier, last time we met was we use machine perfusion, ex vivo perfusion. And sometimes this is where you connect an organ to a bypass machine and you actually perfuse the organ with blood and oxygen, and you warm it up. And we're using it in livers, kidneys, pancreases, and you can see actually that if you place a kidney on the machine, obviously the first part of the blood flow goes down because of the severe ischemia reperfusion injury. But then it starts to auto-regulate itself, actually. The blood flow starts to stabilize, we think. And that's a process called, auto-regulation. So the kidney has got its own internal system of trying to do that. But we don't surgically perform the nerves. We're not that good. Yeah. We'll leave that to the plastic surgeons. Yeah.
Thank you for your answer. Now I'm reading the second question from anonymous attendee. Is there any incompatibility with development in pediatric transplantations? How often is a new operation done?
Could you repeat the question, sir?
Is there any incompatibility with development in pediatric transplantations? How often is a new operation done?
Any what sort of development? What sort of?
I think the question is, Pankaj, I think they're trying to ask when the child is growing, what happens to the organ?
Okay. Fine.
That's the question.
Good question. So growth of the child, as we all know, is really vital. Okay, because we judge their milestones by how they grow physically, but also cognitively. So when you transplant children, it's important for their physical, but also their cognitive development as well. So the child grows around the organ. Okay, so the kidney in the abdomen, it's obviously a large organ, but the child grows around it. But the key thing to remember is that the joins that we do, they also they cannot really grow because the sutures that we use are not dissolvable. So sometimes what happens is that those joins, those anastomoses, become narrowed, as the vessels grow. And that requires intervention to try and go in and open them up again sometimes. So that can be a problem. But the kidney itself doesn't grow as such. I think the liver sometimes does, but the kidney does not itself grow. But yeah, but the child does grow around the organ, and that's important. In fact, you can see them growing quite nicely after a kidney transplant.
So one comment from me. Did you consider using any absorbable sutures or interrupted sutures for the kidney transplantation?
Yeah, good question, sir. Good question. So we didn't consider using absorbable actually, but interrupted, yes. In fact, some of the transplants that we've done recently in very small children, we've done half the anastomosis continuous and then the other half interrupted to allow for this growing. I don't know in your practice what you use.
Yeah. We do the quite the same thing, like half continuous, then we put the interrupted just to leave some space for the growth.
Exactly. It's something that we've just started to do now, actually. So I think that's one way we can get around that problem. Yeah. And I think for the liver, they always use interrupted anyway.
Thank you very much. Third question. Hi, sir. I'm a first-year medical student in Lokman Hekim University. I was wondering, are there any odds as using 3D printing as a temporary solution and to cure the defected parts of the body with stem cell studies instead? Thank you.
Yes. So as I mentioned, I think there's lots of interesting work going on around the world trying to use stem cells for defects. Now, there are some centers around the world, including some in the UK, that are using this machine perfusion, as I was saying, in order for us to look at how we can use mesenchymal stem cells, or progenitor cells, or pluripotent cells, putting into the kidney to see if they can help with regenerative properties. So increasing mitosis, for example, reducing cytokine responses. So there's some good work coming out looking at that. And Lauren Brazeley from New York, I think, has done a lot of work on this and published recently, I think a couple of years ago, where she had 5 kidneys without mesenchymal stem cells put in and 5 kidneys with mesenchymal stem cells on ex vivo perfusion system, where you can monitor the kidney and look at it. And she took biopsies and she's shown that actually the kidneys with the stem cells infused can actually regenerate. So that's quite interesting work. I mean, the question is whether you can do this in vivo. I think that will be difficult. I mean, you don't know how these cells sometimes behave, whether they go cancerous. That can happen, right? And how can you control that? And what are the ethical issues behind that? So it's not so straightforward as going from the laboratory to the clinic. I think there are lots of obstacles to pass. And how do you convince someone to take that therapy as well? It's quite difficult as well to take an organ that you've regenerated, I think. And also, I think the problem with stem organ regeneration is scaling up. Yeah, so going from you may have organoids, or you may have a discrete collection of cells that may then develop into a functional unit. But then, how do you scale that up to a full-grown organ? I think that's another rate-limiting factor as well. But I think there's a few Nobel Prizes in this, so I'm sure some of you can start this journey now for us. I think. So I think it's very exciting, and we're something that we're looking into as well. I think the most important thing is look after your organs. Don't smoke. That's the most important thing. Eat healthy, and don't get high blood pressure. So I think prevention is always better than cure, isn't it? So I hope that's answered some of it. But that's a completely different lecture. Yeah.
Yeah, absolutely. Thank you for your answer. For fourth question from Zehra. Good evening, Professor Çendak. Thank you so much for your presentation. I am currently a first-year medical student in Hacettepe University. You had mentioned the need to explore the child body on the surgical table. On this note, I have heard about mixed reality devices that can allow surgeon interaction with virtual models, and I was wondering what your views on this were. Thank you again.
Yeah, good question. Good question. So, I mean, since this work's come out, people are using VRs as well. And some of you may have heard of this. So I think Professor Dasgupta, who I showed you with the prostate, he's very keen on this VR application. I think he's got this sort of laptop device that you can kind of put over the patient, and you can see the anatomy inside, in a sort of virtual reality sense. And I think he's tried to use that for some of his cases. I think one of the problems with VR is you don't have that much tactile feedback as well. That's something that I think people are trying to develop. So you get a visual perception of it. It's hard to get tactile feedback from that. I think these are all modalities and ways in which surgeons use for planning, right? So it doesn't have to be necessarily 3D reconstructions or 3D printing, or if you feel the technology is there to help you de-risk a procedure, you can use whatever you wish. Sometimes a combination of all of the things would be useful. I think in the future, you're looking at an operating theatre where you're going to have one whole unit, which has possible VR, has possible rapid 3D printing, who possibly has a way in which you can analyze real-time blood samples intraoperatively. That's the ideal future of an operating theatre, perhaps even with an autonomous robot. Again, there's lots of ethical issues about these things as well. And I think one of the key things is trying to validate all of these different modalities for patient safety. We can create all these things, but it has to be validated appropriately, I think, and for it to be translated into the practice as well. That's another key point I think we have to remember. So it's important to have the stuff there, but are we using it just for the sake of using it, or is it actually going to be useful? And then how safe is it? I think those are the key things that we need to think about. But yeah, sure, the technology is expanding all the time, and it's very exciting. Yeah, I mean, artificial intelligence is also fantastic now. So AI is big now. With all the different games and chess and AlphaGo and all this stuff. I'm sure you youngsters out there know everything about this stuff. But AI is big, and if you can create intelligence into these systems to try and predict things, if you like, then that's another great step forward. I mean, there was a paper in Nature, I think, maybe a year ago now, looking at the eye retina, and they used artificial intelligence, which identified, I think, diabetic retinopathy, I think, better than or equivalent to, I think, an ophthalmologist. And then they used the same technology for breast mammograms. They used AI, and AI was better at picking up, cancers and things in mammograms than a radiologist was. So I think all these things are, interlinked, and we can use these different things in transplantation as well. And I think that's another area to explore. Yeah.
After 30 years, I think there will be no surgeon in the OR.
There you go. Absolutely. I mean, Nikos, Nikos Kasaris, Nizam, they think the same. I mean, you could have an operating theatre where no surgeon is there. In fact, surgeon could be sitting at home like Professor there and just directing everyone's orders.
Push the button. Yeah.
Exactly. So, and just watching things with a cup of tea, and that would be nice. But I think, again, there's nothing like being in the operating theatre with the patient. I mean, for safety, I think.
Yeah, sure.
Yeah.
Thank you very much for your answer.
Okay.
We have another question from Said. Can we trust the materials we have used for transplantations in long run for patients' health? Are they lifetime useful or just temporary solutions? Thank you very much.
Could you repeat that one? Sorry, what was it?
Can we trust the materials we have used for transplantations in long run for patients' health? Are they lifetime useful or just temporary solutions?
So I think you're talking about the organs themselves, presumably, yes?
I guess. Yes, I guess.
Because we don't put the plastic inside, obviously. So I mean, look, yeah, sure. Kidneys generally, I mean, I think our longest patient kidney transplant lasted maybe 30 years, I think, something like this, which is very long. I mean, they're off immunosuppression almost by this point. The kidney accommodates to its immune environment. But generally speaking, I mean, I don't know in your experience, Professor, but I think in our experience, kidneys may last up to a good kidney up to 10, 15 years, I think. And then the trouble is the immunosuppression you take can also damage the kidney itself, and obviously rejection episodes and infections and other things, and you're at more risk of getting certain cancers, for example. So it depends on the quality of the kidney you're getting. I mean, generally, children, we aim for getting a good quality kidney from a good donor, ideally. They're the higher priority on the waiting list. And so you're not going to put a 65-year-old, 70-year-old kidney, from a diabetic or a hypertensive into a child, because you want that child to have the best kidney longevity. Because the more transplants you have in your life, the more sensitized you get as well with antibodies, and that makes you harder to transplant again because you've got antibodies inside you from the previous transplant. So, there are complexities immunologically as well with having solid organ transplants. So, as I said, it's best to have it'd be amazing to have a scaffold where you can use your own genetics to create, stem cells you can put inside the scaffold and have an organ ready for you when you need it. That's the ideal situation. Like you remember, 1954 was the first identical twin transplant in Boston, and the recipient didn't need any immunosuppression. It's from identical twin living donor transplant.
Identical twins there.
Yeah. So that was a landmark operation in the 1950s, living donor. So we try and put good quality tissues into human beings, ideally, as best as we can. And I think, as I was telling, your machine perfusion now is there to assess the quality of organs. I mean, I can give you a talk on this another time if you like, but machine perfusion is where you can assess the quality of an organ and possibly manipulate or precondition the organ to make it better, in inverted commas, before doing the implant. So if you're not sure about an organ, you put it on the machine, you see how it performs, what's the urine output, what's the renal blood flow, I'm not quite sure, then you can discard it if you want to. So this is a way in which we can help the organ donor pool to increase it, to make as accessible, if you like, to potentially discarded organs, making them better. So again, it's an example of using innovation and technology to help, the cause, if you like, machine perfusion.
Yeah, thank you for your answer. And another question from Jem. Thank you for your great presentation. When will the time come for 3D decellularized livers for human transplantation?
Yeah, again, excellent question. I think there are there's some work going on again around the world, especially in the Royal Free Hospital, where I showed that slide. That work was done. So yeah, I mean, again, the main problem is vascularizing the organ. Getting the blood supply right, and that you can create an organ with cells in, and you can get it to function. But the key thing is really to try and maintain vasculature. And to try and, because that's ultimately what's driving the organ. You need to connect it to blood supply. So that's one of the rate limiting steps. So to create a whole new liver based on that was going to take many, many years, I think. Again, it's problems of scaling up from small cells, scaling it up, making sure that the whole liver is, for example, it's a big organ, making sure all those cells are correct and not going to be cancerous, for example, or not overgrow themselves. It's a complex dynamic, if you like. Of interactions, and there's a paper published in Science from the Cambridge group, I think a few months ago, where they put liver organoids into a deceased donor liver. Again, put it on the bypass machine perfusion, and they showed that these little liver organoids actually embedded themselves within the liver and actually had some sort of physiological function, right? So that's another way of kind of regenerating or repairing, if you like, an organ, which you can do as a proof of concept. But to create a whole new organ as itself, for implantation purposes, I think we're a few decades away from that. I think. I don't know if you agree, Professor. What do you think? So yeah.
Thank you very much. We have another question. I couldn't fully understand how organs produced with a 3D printer gain functionality. I would appreciate it if you could explain. Thank you very much for your inspiring presentation.
Yeah, so thank you for the question. So again, the plastic models are not used for transplant. They're used for planning. That's the first thing. So we don't put those plastic organs inside. And as I said about the the whole concept of 3D bioprinting, that's a different to 3D printing. So 3D bioprinting is where you actually use cells in a 3D printer to layer up a scaffold, for example, in a particular arrangement to gain function. So that's a different concept to 3D printing for physical models.
I can add a couple of things, maybe. Well, right now, trachea and bladder is printed, and there's some clinical applications for that. But they're very basic tissues or organs. But complex organs such as liver and kidneys, you need to have a scaffold and vasculature, as Pankaj said, and you need to form an architecture around the vasculature in certain manner. So it's very difficult to right now print it. They're still clinical, but probably it will take 2 or 3 decades until we see them on the operating table.
Absolutely, yeah.
Yes, thank you. Our last question from Mehika Esra. Dear Mr. Chandak, thank you for your great presentation. I have a question. How often do you operate these transplantations? Thank you.
Yeah, good question. So, in terms of pediatric transplants, we work at 2 big hospitals. We work at Great Ormond Street Hospital and we work at Evelina Children's Hospital. And between them, we do about almost a third of the whole UK's pediatric transplants for a year. So we do about, maybe it can range between 35 to 40 a year, something like this, living donor and deceased donor. We've got quite a large living donor program there. And I would say it's probably one of the largest series in the world, to be honest. And we do not just complex children surgically, but we do immunologically high-risk children as well. So Professor Mahmood pioneered antibody incompatible transplants, in children as well, with Nikos and Professor Dorling. So what they did was, if you have a child who's not compatible with their living donor, we can actually remove antibodies from the child using immunoabsorption or plasmapheresis, for example, get the antibody level low in the child, do the transplants successfully with high-dose immunosuppression. So we can cross difficult immunological barriers. And of course, now it's part of, we can have them as part of the kidney sharing scheme as well. But yeah, we do immunologically difficult and metabolically difficult children as well. So sometimes we do combined liver-kidney transplants or sequential liver-kidney transplants in, for example, conditions such as oxalosis, primary oxalosis, and MMA, which is another metabolic condition. So we have to correct the liver defect as well as the kidney defect. So we work quite closely with the liver team there as well. So that's for the pediatric side. For the adult side, we do adult transplants as well. We do about, at one stage, we were doing almost up to 270, 280 kidneys a year, something like this, quite a large volume. We do pancreas transplants as well, combined kidney pancreas transplants for diabetics in kidney failure. And we did about, maybe about 30 of those a year as well. So it's quite a busy unit. We don't do small bowel or anything like this, which I think it will be a very exciting thing to do as well. So yeah, so you're all welcome to come and do some experience with us anytime. And once things settle down with the pandemic, it'll be very nice to welcome some of you to come. Yes, it'll be a pleasure.
Apart from the numbers, the Guy's Hospital is a very good published center. So another important thing is not the number, the quality of the scientific data you pull out of, from your clinics. So you can do 500 kidney transplants per year. There are some centers in Brazil doing 500 kidneys, but it doesn't mean anything. I mean, they're doing commercially, so they put the kidney and, no scientific data, they don't collect anything and no follow-up, and it doesn't produce anything. But, you can do 50 100 kidneys per year, but you can publish in Transplantation and Nature, and as Pankaj, you can actually invent a new way of thinking. So, you know, for you, I think that's the most important thing, the quality of the work you're doing. But
Yeah,
your number is quite high, actually.
Yeah, absolutely. And that's why I encourage all of you, as the professor was saying just now, I think it's important to always keep your eyes open, and you can learn so many things from scientists, from engineers, to answer clinical problems, and I think it's very nice to advance human knowledge like this, to work with colleagues. And the real amazing science in clinical medicine happens with collaboration, actually. Gone are the days where you have a single surgeon or a single scientist working now. I think collaboration is really the big thing. And we've come to Turkey many times to collaborate at different congresses. It's been fantastic. And I think that's how knowledge is exchanged, and how the scientific community flourishes, I think, with this. Because, a single laboratory will not know all the answers, or a single unit, no matter which specialty you go into, will not know all the answers. So we have to rely on, getting the expertise from different people to come together to solve a common problem, I think. And at the center of that is you guys, actually, because you guys are going to be there, seeing the patients coming in, seeing, what the problem is, identifying the need for how we can improve human health. So really, that should be the drive, the stimulus, as I said in my quote, there is only one rule: put yourself in the patient's place. What would you want? Basically, if you were sitting there with you, if it was your mum or dad or your relative who's not well, what would you want? So I think these are, important philosophical concepts, I think, and important to try and, in your training, to not just go from A to B to C to D and learn things, but to try and think of a bigger mind, think outside the box. I think this is the important thing.
Thank you for answering our questions, and for your, again, wonderful presentation. And now we have, I'm looking, no new questions. We can end the webinar here. Thanks again to you and Professor Tüzüner for here being with us.
Perfect.
Thank you so much.
Thank you very much. I really enjoyed myself. And if you need anything more from us, please get in touch. It's always a pleasure. So
when is the fourth season for Crown is coming out?
When is that? Oh, fourth season. That's I don't know, but I'm in talks with the director already for next season. So we'll see.
Okay. Okay. Thank you very much, Pankaj, for your
Yes. Yeah. Really nice to see you all. Thank you very much.
Thank you. Bye.
And very welcome to London anytime. Yes. Thank you.
Thank you so much.
You. See you soon. Thank you. Bye-bye.
Bye.
Bye.
Bitirdik mi? I also want to thank you so much, Mr. Shandak.
Oh, yes. Pleasure. Pleasure.
It was